the IJB's Risk, Audit and Performance Committee today, Wednesday the 19th of November, 10 a.m. Welcome everyone, and I'd particularly like to welcome Rachel Marples, Deputy Chief Nurse, and Nikki Cooper, Principal Information Analyst at Public Health Scotland. I believe you're attending for the item on community nursing role test of change. So thank you for being here and welcome. I'm going to hand over to the clerk now to take us through the housekeeping. Thank you.
Thank you, Chair. The meeting is being recorded and published online after the meeting. Could all attendees leave their camera on but switch off their microphone when not speaking, but switch on both camera and microphone when you are invited to speak so that this is picked up on the recording. If you wish to speak, please use the raise your hand function or indicate in the meeting chat and I will alert the Chair. I will now do a roll call and would ask that members confirm their attendance when their name is called so that this is clear in the recording and can also be recorded in the minute. Chair.
Present.
Richie Johnson.
Present.
Councillor Cook.
Good morning.
Hussein Patwa.
Morning. Present.
Thank you. And we have apologies from Jonathan Belford. Thank you, Chair.
Thank you very much. Item 1.1, are there any declarations of interest or transparency statements from members? Nope, there are none. 2.1, there's no exempt business for us to determine today. 3.1 is the minute of our previous committee meeting, 27th of August. Are members content that it's an accurate record of the business transacted at that meeting? Any problems? Nope, no problems. Take it that's approved. Minute approved, thank you. 3.2 is the business planner. Are there any questions? See, Hussein, you've got a question on 3.2.
Yeah, thank you, Chair. It's not a question on the planner as such, and I hope John, Councillor Cook, won't mind me slightly stealing his point. We had a discussion yesterday around potentially refining the planner slightly to improve readability and perhaps to take out some of the historical information as the planner grows time after time. And that was in the context of the IJB papers. It's simply a comment that could we harmonise any changes that we make to the business planner across all of the committees, because it may well improve the readability and help members going through if we have a similar formatting across all of the various groups.
Okay, thank you. So that's currently ongoing review of the presentation.
Emma was going to see what can be done in consultation with John and others. It may well come through in time, Chair, but it was really just to make sure that we keep a consistent format across wherever possible.
Yeah, absolutely. I think it's essential. If there are any improvements in the formatting, the presentation, then we should obviously be doing that, and the committee should obviously reflect the practice from the IJB. So look forward to, I guess any adjustments will just be made in time for the next meeting, and there'll be ongoing discussions. Good, glad to hear that. I'm noting that at line 41, digital inclusion, there's a request to remove this because that's the issue has already been dealt with by 2 IJB Insight sessions. And it will be included in the upcoming digital strategy. So that was line 41. So that's coming out. That's just for information. Are we content with the business planner? Yes, all content. That's the business planner noted and approved. Grand. That takes us on to our first item of substantive business, 4.1, which is the community nursing role test of change. Rachel and Nikki, did you want to introduce with some initial comments? Would that be a good way to start? Great, you've got a presentation. Excellent. Over to you, folks.
Lovely, thanks very much. Thank you for the very introduction, Chair. I'm Rachel Marples, as you said, Deputy Chief Nurse for Aberdeen City North. Delighted to be here today with my colleague Nikki, who's going to kick off our slideshow.
Yes, thank you very much for having me today. I'm Nikki Cooper. I'm a Principal Information Analyst within the LISC Grampian team within Public Health Scotland. So hopefully everyone can see my presentation okay. So I'll just kick start. Fantastic. Perfect. So maybe for those of you who haven't heard of LISC before, we are the local intelligence support team and we are part of Public Health Scotland. So the LISC team is funded by the Scottish Government with the objective to support local partners in primary care and health and social care partnerships. So we have a team of 62 and we are split across the country into geographical areas and 5 of which are within the LISC Grampian team. So as part of Public Health Scotland, we have access obviously to national data sets and we're fortunate to have links with colleagues all over Scotland to help facilitate collaborative working across our partners. Our work is fully dependent on the priorities of those local partners, and although it's predominantly data and analytical based, we can get involved in other things as well. In the LISC Grampian, we are very fortunate to have a very established link with yourselves in Aberdeen City, primarily with Callum Leask and his team, and we have been involved we have been involved in projects such as the strategic plan review, some of the primary care database, dashboard work, and obviously with the health visitor test of change that we're here to speak about today. Rachel.
Lovely, thanks very much, Nikki. Okay, I'm going to give you a bit of background and set the scene for this project. Back in 2015, the Scottish Government introduced a new universal health visiting pathway across Scotland, which led to the need to introduce an additional 500 health visitors across all of Scotland in order for the pathway to be implemented. That actually turned out to be a lot more than 500 because we didn't anticipate that people would want to work part-time, people would come into the post and not realise it was for them, which led to attrition from the service. And it led to a much younger and more experienced workforce, which meant there was a need for additional levels of professional support and additional postgraduate training, post-qualification. The new pathway was designed to be delivered by specialist community public health nurses and nursery nurses. And so it was a challenge for health boards to anticipate, organise and sort out the funding that was needed in order to keep up with locality need and demand. The increased level of health visiting input that was put into families with this additional pathway also led to lots of stones being unturned with families from that increased relationship and better connection with families, which led to, again, increased need for the families to be working in greater detail with the families. They uncovered lots more problems, which again led to increased need and increased demand. Moving on to 2005, the Scottish Government introduced in March of this year an action plan which strengthened the need for the existing pathway. It was recognised that health visiting had been making great inroads in terms of early intervention and prevention with families from these additional visits that came from the pathway. And they were, getting on top of developmental concerns, recognising and responding to neglect with families, reducing the numbers of the need for children to be on the child protection register, and also those experienced neglect, etc. However, when the pandemic struck in 2019, 2020, all the arrows and the lines on the graphs from the inroads that health visitors have been made started to go in the opposite direction. And we really lost a lot of ground that had been made with these families. So this action plan was brought in, strengthening the need to continue with the number of health visitors that we needed across Scotland and to continue with recruitment, retention of these specialist staff. It's been recognised that working in the post-COVID world, services have seen a significant increase in the need and complexity of the families that they're working with. And that's not actually unique to health visiting. There's a big increase in numbers of the families where English is not their first language, families with no recourse to public funds, families experiencing poverty from the cost of living crisis, also long waiting times from existing children's services offering supports like paediatrics, CALM services, etc., and also the widening inequalities gap. There's a need for all services to consider a realistic medicine approach, working in that context, working with families as partners, responding to the changing landscape in terms of neurodiversity, individualised care, and the need to look for innovative asset-based answers to the knotty problems that services are experiencing, trying to improve the reach of services and outcomes for families. It was seen that introducing the Band 5 role to these specialist teams could be a way of introducing a skill mix would be better enable the service to respond to all these complexities I've just described. The health visitor, the Band 5 role was also seen as a way of mitigating against not having enough specialist community public health nurses, and being able to pick up various aspects of the pathway, non-pathway contacts, new to area visits, etc., and to be able to introduce some really specific public health aspects that were coming out from the pathway. So that's a little bit of background there that Nick is going to lead on from now, and then we'll come to the next steps.
So our ask then was to evaluate if the additional 3 community nurse Band 5s with the addition to the health visiting team had in fact helped reduce the health visitor workload. So to determine if how we would go about the ask, we set up a working group, and that included colleagues from LIST like myself, partnership colleagues like Callum Leask, and workforce partnership colleagues such as Beth and Murdoch. We then created an evaluation framework to scope out the project, and that helped us to look at current data and maybe some of the national data sets which we could help align to the ask. It was at that point there that we agreed that due to the small cohort, in particular, it was 3 community nurses, and at that point it was then down to 2 community nurses, that we would be unlikely to see actually any impact within the data, and would require more of a qualitative contextual view from that involved in the test of change. So apart from that, we did have a look at the internal data just to have a little look and a wee kind of have a wee feeler around, and in particular the community nurses' caseloads, which did identify the types of tasks that they had been delivering on, and the key task which Rachel's previously mentioned was that new to area contacts that they were delivering on, which would have been previously carried out by a health visitor, so essentially taking away some of their workload. The 2 community nurses and all health visitors were invited to feedback when we were conducting some semi-structured interviews. We invited all health visitors within that role, even if they'd been involved directly in the test of change or not. So during April, March this year, we conducted a total of 7 semi-structured interviews. Each cohort had slightly different set of questions depending on if they were a health visitor or a community nurse, but all followed the same sorts of themes of those with training and development, communication, and the role satisfaction. So although we only conducted 7 of those interviews, there were some 4 common themes that were observed during each of these. So the first one was the team and the communication. So it was found that across the team with the health visitors, community nurses, and in fact the nursery nurses, there was a lack of maybe understanding and expectations of those roles and what everyone did within the team. So that was one of our observations, was maybe to have that open and clear communication between the team to help address this for working more collaboratively in the future. Our second was to potentially identify further tasks. So as I said, we could only identify the news area contacts when we looked at it, but it was potentially look at further tasks that the community nurses could take on. That is obviously caveated with the fact that the core pathway that the Scottish Government, obviously it's supposed to be health visitors, so the community nurses couldn't really take away anything from the core pathway there, but look to see if there was anything else that they could help support with. The third observation was very much linked to the second, in that the community nurses should be having open discussions with health visitors, team leads, to identify the types of areas, types of training that they would need to further develop on to enable them to actually take on more tasks, and therefore reduce the workload from the health visitors even further. And the fourth, and this was predominantly with the community nurses that we interviewed, was the fact that they would have some realistic expectations about future development within the role. So just a clear expectations kind of set out if this role would then develop into fast track health visiting, or just having that clear expectation from the get-go there.
Thanks very much, Nikki. Back to Rachel here. So next steps, we're looking to strengthen and enhance the health visitor establishment, of course, because that is the key backbone of delivery, and that's what's required for the pathway. But we're given that we have to work within a tight financial envelope, which isn't going to get easier anytime soon. So we aim to continue to monitor and look at the community nursing role, look for opportunities as to where they can expand, as Nikki said, in terms of improving nursery link-ups and accessing families in a different way, but also delivering specific important public health messages like improving numbers of toilet learning, which is a real issue for schools at the moment, improving immunisation uptake, again, which is a real public health concern at the moment with the national apathy for immunisation uptake for children, and also responding to the child healthy weight and increase in type 2 diabetes in the younger population, which again is of great concern. How can we use our community nurses to help build on that? Also thinking about looking for the potential for changing the skill mix within the team to make it a more financially viable option. That may well come from the action plan that came in from 25-26. It talks about working in a more collaborative way with different community services and skill mix within the community. We haven't got the full detail of that from Scottish Government yet, but we may well be able to lead on that in Grampian once more details come out from Scottish Government. Also thinking about linking into the aspirations of the wider organisation in terms of making every opportunity count for every clinical practitioner. How can we use our band fives to, think of every opportunity or interaction they have with families in a really holistic way, not just what they're there to deliver, but what's going on in the wider context. And then also monitoring the impact and the satisfaction of those staff that are in those roles. Does that lead to them going on to the health visiting training and make for a more sustainable model? As I alluded to earlier, we have found in the past we've ended up with people coming onto the training not fully understanding the role and deciding it's not for them, which isn't economically viable moving forward. We have to make sure that we are recruiting and retaining the right staff. And just one other thing to say also, to think that the band fives could be crucial in terms of engaging with families themselves, getting feedback, involving the families of Grampian or Aberdeen City into service design, and really helping them work with how we work with children's services in the wider context moving forward. And happy to take any questions. I think that's our last slide, yes. Nikki.
Yes, it is.
Okay.
Yeah.
Thank you very much, Nikki and Rachel. That's really helpful. It's really good to see the contribution of LIST towards our transformation efforts. I think we've got a couple of questions. So first in the list is Hussein.
Thank you very much, Chair, and thank you, Rachel and Nikki, for the presentation and also for all of the work that you've done. This was a really interesting report to read, and I agree with you around the opportunities and making every opportunity count. You touched on this when you mentioned the skill mix across teams. And reading the report, and there's mention there about kind of unexpected. I think there were two posts which were not available for various reasons. And it did lead me to think, given the financial constraints that we're currently in and the vacancy controls that we're managing, how much flex do we currently have within the organisation for cross-skill training and being able to deploy from other parts of the organisation if we need to fill posts for kind of unplanned events, people going off sick, maternity leave, whatever it may be, so that people do have that ability to cross-fill roles. Is that something that we're currently thinking about, or is there scope for that, or is the vacancy controlled to the point where we don't have that flex anymore?
Thanks very much for your question, Hussein. It's Rachel here. Nikki, do you want to stop sharing and then we'll be able to see each other? Okay, so great question there. The health visiting pathway is designed to be delivered by specialist community public health nurses who are Band 7 practitioners working in the health visiting teams, and that is the situation across Scotland. They are supported by Band 4 nursery nurses, but it is very specific in the Scottish Government ask that it has to be qualified health visitors who are delivering the pathway contact with families. We know that the pathway has generated a huge amount of work. The pathway really is just the backbone. It generates thousands of additional visits every month as we uncover the need and the complexities within families. Where there is ability for other skill mix to pick up on some of that, that's where that comes in, picking up that additional work. However, some people, Hussein, would argue that that is getting away from the intentions of the pathway in the first place, because the whole intention of the contacts from the specialist community public health nurses is that they're building those relationships with families. They're really getting to know the families. They are the direct contact. They're the named person, and it will be them that will be going in and out without somebody else coming in and being involved in that family's care. So, but we have used the Band 5 in Grampian to make up for that shortfall, thinking about how can we make up for the shortfall of having those specialists when we've got to respond to the needs of families. So it's a really fine line. We wouldn't be able to pull from other services to fill the gap of the specialist practitioner, but we would be able to fill gaps for specific pathway activity in the same way that we've been using the 5s. Does that answer your question?
It does, and thank you for the context around that as well. It's really helpful. I appreciate it.
No problem.
Thank you. Fiona, did you want to come in on this point? Or did you?
Yeah, happy to. Thanks, Chair. And Rachel and Nikki, thanks for the presentation. I guess one of the key things for coming to RAPC about this is, as Rachel alluded to, the health visiting pathway is something that's it's direct from the government. Since COVID, we've not been delivering that in Aberdeen City, so there's a risk that we are holding because we've not been delivering that pathway as expected. And I think this was a model that was introduced to try and enable us to release capacity for health visitors to be delivering the pathway that they need to do and this model. And I think that was it. We wanted to do it as a bit of a test to see if it was effective. And I think, you know, it's small numbers, but I think that it's to make sure that to give you the assurance that the change has not had a negative impact on the service delivery. So that was really what I want to come in and say. So we've not been delivering what we needed to. It's been a huge, I mean, we've had it as a high risk on our risk register for a long period of time since COVID. And I think this is a model that can help us to move forward. So it was really just to have that conversation here to give you the assurance that the changes that we've made are making it was the right decision to make. Thank you, Martin.
Grand, thanks for that. Thank you. Over to John.
Thanks, Martin. Yeah, and apologies if I've misheard this, but I had a couple of comments that suggested that we'd recruited people who didn't quite understand what the job was. And if that is the case, what are the lessons that we've learned from that, both in this context and more broadly?
John, are you referring to recruiting to the health visitor training itself or recruiting into the Band 5 role?
Not sure, both probably.
Okay, so I need to give you a little bit more context then, and I apologise if I haven't taken up too much time here, Chair. And yeah, cut me short if necessary. Pre-2015, the health visiting teams were made up by a variety of different skill mix. When the health visiting pathway came in 2015, it was said we wouldn't have skill mix in the team, we would just have the specialist practitioners. However, as Fiona has said, Various teams across Scotland have not been able to do that because the recruitment hasn't been able to keep up with demand for the specialist practitioners. So we have done some mitigating of that with the Band 5 role, taking up some of the other role. The Band 5 health visitor role is very specific. It's a Band 7. It's a very senior practitioner role. It's not generally recognised out there what it is that health visitors do, and many of you round the table here may not either. People think they go out, they drink cups of tea and they weigh babies. You know, it's not that at all. It's child protection, it's domestic abuse, it's complex. It requires a highly skilled, highly professional, experienced practitioners. And in the need to significantly increase the workforce by 500. We have on occasion not got that recruitment quite right because we haven't, the staff that are applying to come into the service haven't recognised the really specific demands of the role, and they've come into the role and thought, do you know, that isn't perhaps for me. And that's where I perhaps didn't explain that well enough initially. Does that explain it better there?
Yeah, it does. And have we learned the lessons and got it right for next time, as it were?
We've absolutely got it right. We've been changing the recruitment process year on year. We're going to change it again for next year. We're going to do different levels of, you know, we're going to do workshops with, you know, so yeah, not to go into too further detail. Absolutely, we've been learning year on year.
Thank you very much. Richie now.
Yeah, thanks both for the presentation. As I've said, really pretty interesting stuff and really important service in terms of that prevention, early intervention activity. So just one sort of comment and one question. The comment is just in terms of tests of change generally. And I know that the paper is there. It is a test of change, and you want evidence how that can inform future service and such like. And it's interesting. I think part of the learning that you've reflected is the nature of the test of change and how you can actually apply that. You've had some challenges around about people being off and such like. So I think that's in itself a bit of learning or interest there, just in terms of how you, others might define how you do a test of change. And my comment was kind of related to that. One of my other roles is the chair of Financial Recovery Board within the NHS. And one of the deep dives that we're going to do in December next month, I think it is on tests of change, funnily enough. And that's around more generally, how can we make sure that they're doing what they need to do? And it's not to say they haven't been, but just it's about making it sustainable. And have we got, I guess, can we sharpen up our approach to test of change in terms of financial sustainability, service sustainability, all these things. So just as an aside, and I guess Fiona might be connected into that in due course when we come to talk about that. So my specific question was around early intervention and that kind of prevention part of it. And I was really interested, as you said there, about the COVID time when that kind of knocked it back. And I know it's something that's quite hard to evidence impact of early intervention and prevention activity. And I wondered if there is some evidence that you've seen, I guess, over the last few years to say, well, when this kind of service wasn't in place, then what the consequence of that was. And is that a sort of a different view of, I guess, evidencing, if it's not there, what the impact can be, just to reinforce the worth and the importance of this type of role and that prevention role?
Yeah, thanks very much, Richie. So just to come back to the start of your problem there, thinking about tests of change and Plan, Do, Study, Act and the tools that we use in that. We demonstrated during this test of change the importance of actually, you know, following through the process, doing the Plan, Do, Study Act, going back to the beginning, thinking what needs to change and thinking about how we can apply what we've learned to other projects. And one of them being the real need to clarify roles and responsibilities when you're changing the makeup of teams, and that applies to every team. Be really clear with the people that are coming into post and also everybody else working in the wider team what it is that they can do, what are the boundaries and the parameters of where they're working. And we learned from that during this, and we would do things slightly differently moving forward and maybe go at a little bit of a slower pace, make sure that we get everybody on board. You know, some people say Plan, Do, Study, Act, please do something, anything, but you know, you always have to bear in mind the consequences of the actions of what you're having on the clinical team. So we have learned from that. In terms of early intervention and prevention for what happened with COVID, absolutely. You know, we saw a huge increase in children not reaching their developmental milestones. huge increase in children not being toilet ready when they went to nursery and school, which is a huge regression from where we were at. The way that children interact with each other because they were deprived from that nursery exposure, parental expectations of what their children are supposed to be able to achieve at certain times because they haven't been exposed to other parents, other children of the same age. The impact was absolutely massive, and it was directly related to the COVID-19 pandemic, the isolation of families, lockdown, and the inability of the health visiting service to be able to properly deliver on what the ask from Scottish Government was. So absolutely, you know, and that's partly why this action plan has come in 25-26. It's a long term, it's 10 years. There are lots of actions from Scottish Government within that action plan, which is going to filter down to the abilities of the board to deliver on. So yeah, really important. And when we're thinking about early intervention and prevention, children's services is where we have to start because they are our next generation.
Thank you very much. Callum?
Yeah, just to add to that, Richie, I mean, I think the point around tests of change is really interesting one. I guess when we start out with tests of change, we have an idea about how they may go, but the reality is that they may go in that direction and they may go in a different direction. And that's okay so long as we take the appropriate learning from that and think about how we apply that moving forward. And one of the really interesting things about this bit of work is that, notwithstanding some of the challenges around staffing, what it has shown, even with a small number of staff, is that it is feasible in the appropriate context to displace particular tasks from health visiting to other members of staff. And obviously that's a really important point when we're thinking about the workforce challenges that we've got and the financial challenges that we've got. And so when we're working within that context, it's really, really important that we think innovatively and we try different ways to deliver services. I think one of the really useful things about bringing this to this committee is, one, to provide that assurance that we are undertaking those types of innovations, but also I think it's really, really useful because it's a really good example of the types of collaborations that we've been doing with Public Health Scotland for kind of some number of years now that the committee may not be familiar with. And so I think it's also useful to show that these are the types of kind of collaborations that we've got that are really, you know, helping us, you know, maximise the use of the limited resources that we've got.
Okay. Thank you. Richie, you want to come back?
Just really briefly, thanks both, and thanks, Callum. And just I guess, just to reinforce, by definition, it is a test of change, and by definition, some of them may not work in the way they were expected to work. And certainly, I wouldn't want, I guess, that innovation, that effort to just try and do things differently to be kind of compromised. So I think they totally recognise that. But I guess as you kind of both reflected, if there's learning around how that can be done even more effectively, then that's great. So no, thanks for that.
Grand. Thank you. Yeah, so could I ask a couple of questions at this point? I think that's a really important factor that we've just heard about, the increase in pressures on health visitors, growing needs, developmental issues, and families having difficulties in supporting children. So that's putting additional pressures on health visitors. Will the community nurses replace health visitors, or is that an extra capacity that's going to be introduced? Because the community nurses seem to fulfill one of what's been a traditional function of health visitors. So, you know, are they going to just take on that function but as a separate resource rather than adding capacity adding resource onto the team? Does that make sense?
I'm happy to come in there. We very much see them as adding capacity to within the team, Martin. So working complementary in the complementary alongside the health visitors. It allows us to work we have a recommended number of health visitors per head of population 0 to 5. It means we can work within the parameters of that to the absolute specific, and the community nurses can help to pick up where there would be a shortfall because of the additional need that's put on to the health visiting service. So very much complementing the service, picking up what's coming through from the health visiting work so that they can concentrate on delivery of the pathway.
Okay, so does that mean that the workforce increases, the workforce volume increases?
It does, but it increases in a way that we are still being able to respond to need, but we're able to do it within a better financial model because the community nurses are much cheaper to employ than the health visitors.
Right. Okay. Thanks very much. And I think that the evaluation has been really important, given that it's a relatively modest evidence base. I think that it's been possible to really do some serious qualitative analysis, and they have the post itself definitely makes a difference. Could I ask about the kind of the overall more general context of this test of change activity? There was an image there of realistic medicine, and there was mention of making every opportunity count. And so last week we had the Hope Conference, and I'm just wondering if the transformation, if the mood for innovation is within that wider movement towards towards empowering patients and individuals, because I think that movement will give some impetus, will really help to motivate and encourage us to be maybe a little bit bolder, a little more creative in service redesign.
I think, yeah, absolutely. There is the appetite for innovative change and involving families in how we develop services moving forward, what services are delivering. Absolutely. The way that the health visiting pathway is designed is to work in partnership with families so that health visitors are no longer the experts going in, hello, I'm the expert, I'm going to do A, B, and C with your child. It's very much, hello, this is who I am, you're the parent of the child, let's work together, you know, what's your experience, what's my interpretation, etc. Absolutely working together in partnership, looking at ways of improving that, improving technological advances, having information available for parents online, responding to digital poverty, etc. There's a whole raft of work going on there, Martin, to make us more efficient and more effective with what we've got, with the resources we've got.
Thanks very much. I mean, what I picked up from the Hope Conference, from the information on realistic medicine and from the other discussions, was in that vein of working more as a team, of regarding the individuals, the families who you're dealing with as part of a team, listening to them more closely. That those principles of subsidiarity and involvement. So that, from my very initial impressions, that does seem to provide a kind of a guide and a framework to help us to drive forward with change, with improvement in service redesign. So
yeah, and you know, without that we can't survive. You know, we'll go into families and use the principles of realistic, the brand questions. You know, thinking about the huge expansion of the children who are experiencing challenges with neurodiversity, you know, and they're all individuals, and there's no single answer for every family. We have to say, you know, what are you looking for? Where do you want this to go? What are your expectations? And it's not always about getting a diagnosis, and that's a really good example of how we have to work with families on an individual level.
Yeah. Thanks. I think that this particular example of the test of change on community nurses, I think it's been able to really get into the granular, into the detailed understanding of how healthcare is delivered and can be better delivered as a partnership, listening to children and families. So very grateful for that presentation. I think that's all of our questions. So thank you very much, Nikki and Rachel, for that really helpful and informative presentation. And thank you for the test of change and for the analysis. So
Thank you very much for having us.
Thank you.
Thank you very much. Lovely to see you.
Thank you. Thank you.
Thanks.
Nice to see you all. Bye.
Turning to the
Bye.
members. Are the members content with the recommendations on this report? Yeah. Grand. Okay. Thanks very much. So we can go on to 4.2, which is the Q2 delivery plan, which is the next one.
Yes, that's
So
me.
Callum, yes.
Yes, good morning. This is the Q2 delivery plan update for the committee, providing an update against all of the priority actions aligned to the year one delivery plan of our new strategic plan. There have been some changes to how we present the reporting for this financial year, and we've made the committee aware of those developments over the last few reporting cycles. So in addition to the updates themselves, we now provide specific information on the reason that particular projects may have an associated brag status, for example, if they are at risk, and also mitigating actions that we are actively putting in place to address those risks. We also provide, where appropriate, some quantifiable measures to give assurance that progress is being made as well. There's nothing in particular that I feel is necessary to highlight at this stage with regard to specific content. However, happy to take any questions that anyone might have.
Okay, thank you. Thank you very much for comments and for the report. Well, could I first of all ask about some of the high-level information that's provided there? There's page 60. There's mention of the target of savings for use of properties. I'm just wondering, is that sufficiently ambitious? Is there further scope? Would there have been further scope to be a little more radical, perhaps, in reviewing the use of properties, or is that a very, very realistic and achievable outcome that really reaches the limits of what we can do in the financial year? So various hands have gone up. Sandy.
Yeah, I was going to say I'll let Fiona come in, but to be fair to Fiona, I'll come in. It's a good challenge, Martin. I think we're trying to strike a balance between reviewing the scope, reviewing the utilisation of all the buildings. That takes a while. Taking staff with us. It is a big thing for people when they are potentially being faced with, we're going to move you to somewhere else. We're allowed to move people, but all of us can relate to, you work in place X for years Y, and then somebody says, we think you should work in place Z. That's a difficult process. I think the short answer is we're going to continue to reduce the number of our premises and probably accelerate the reduction in the use of our premises. That doesn't brings its own challenges. That there's a whole staff component to that. It's a very difficult balance between staff well-being, keeping staff on board, and reducing premises costs. But I would assure want to give the committee the assurance, reducing premises cost is definitely one of our least worst options, i.e. we need to do more of it because it's not directly taking money away from frontline services. So we're committed to that, but we just have to take staff with us as much as we can.
Yeah, I absolutely get that, and I'm noting that in the budget process there's various information on further rationalisation. I think that providing those explanations so that the public and staff have an understanding of the implications of these efficiencies and the reasons, providing the data on the inefficiencies, I think also helps people to get a better grasp of why these tough decisions have to be made, and there's a good reason for it. But yeah, I absolutely agree that we have to have we have to have those conversations and bring staff and the public along with us. Fiona, did you want to come in on this point?
Yes, thank you, Chair. I guess just to build it, we don't own any of the buildings either. So if we come out of the buildings, it's mainly utility costs that we save. So we're very thoughtful about our partners who own the buildings and the implications for them of having empty buildings and places. And also we're it's all that balancing the risk to make sure that we're still serving areas of deprivation in that, because that's where some of our, so it's trying to do all that so we don't have people then having to journey on 2 or 3 buses to get to our services. So, but it's a fair challenge, and as you've already identified, we've got further savings next year, and it is mainly just utility savings that we get, unfortunately. But thank you.
Okay, great. Thanks. That was just an observation on that. Accidentally raised my hand there. Hussein.
Thank you very much, and thank you for the paper as always. It was a question regarding frailty, and there's a comment in there about the resignation of the geriatrician, I think that's what you call them, in Elgin, with the review or view to be taken on how to proceed by September. We've done a lot of work around frailty and discharge as part of the whole system working around ARI. So I just wondered what impact that had, particularly given the rurality of Elgin and wider Murray, what impact that had on the wider system, and any impact it's had on us here in Aberdeen. And also, is there any update, I guess, given that this report looks backwards on Q2?
Fiona.
Yeah, thanks, Chair, and thanks, Hussein. So, and I think this is slightly further complicated because we don't actually manage or pay for the geriatricians and Dr. Grays, but it can have an impact on our service for frail people across the whole of the region. So I think this is where it's difficult, because we host the geriatricians except from the Dr. Gray ones. But I think, so has it made an impact? Not a direct impact. Obviously, there's lots of changes happening with unscheduled care plans and looking at what they're trying to do, and they're looking at a slightly different model in Dr. Gray's and putting advanced nurse practitioners to the front door rather than what we have in Aberdeen, which is a geriatrician at the front door. So we will look to recruit. We know that there's a local and national challenge about geriatricians, but I think there is that opportunity as well, just for us to stop and hold and pause and think about what is it we really, really need going forward, because there is that geriatrician team up there, and is it the right thing to do just to replace a like for like? So that's what we're doing. But has there been significant impact? No, Hussein. I think the service are managing that overall. Thank you.
Thanks very much.
Thank you. Next is Richie.
Yeah, thanks again for the paper. Overall, I think, as Callum indicated, pretty good progress over by the by. So that's good to see. I just looking pretty specific again questions again. Sure, it's more for clarification. On page 47, 4.5, there was a change in description of one of the activities. It's just, I guess, I was just being nosy. What I guess was the catalyst for the change in the description? If I get the thing up as well. It was on day services and page 47. Yeah. It's amended to review daycare provision for people with learning disabilities from the original ones. Is there any thinking behind that? Any implications we should be aware of, or is it just a tidying up?
So
it seemed quite a subtle change, that was all.
Yeah. Alison?
Thanks. Yeah, you're absolutely right, Richie. It was a very subtle change. I think it was the word review. I can't remember what we had before, but it was literally just one word, and I think the service were just a little bit uncomfortable with the word that had been used previously. So just on reflection, they asked if we could change that. It was more of a review than a re-provision or something, I think we had said previously. So yeah, just a very subtle change, just to reflect what they were actually doing.
Yeah, no, that's great. Thank you. That makes sense. And just, I guess, more for, and apologies if this has been explained before, but in the graphics, which again, I generally find really helpful, on page 53, just as an example, one of the graphics is about project by reason, and that then describes a number of, I guess, factors. I just wondered if you could help me just explain how that relates to the other that's on that page. What does actually mean and show, just to help my understanding?
I can
Callum,
come in on
yeah.
I can come in on that. Yeah.
Yes,
so
please.
yeah, so we basically have if for any project which basically isn't green, we ask the project leads to identify what are the reasons for that. And in some of these instances, you might have a project that has maybe more than one reason why it's green. So this is our way to basically categorize, if you like, what are the main causes that are basically stopping us progressing as intended. And so these are groups, if you like. So there might be something related to there might be something related to money in there. There might be something related to maybe missing a deadline in there. There might be something about the resources that we need to actually deliver the project, whether that be workforce, so on and so forth. So it's a way to, like I said, try to categorize the reasons for that. And basically what that allows the senior leadership team to do is that, say, if we have, for example, a variety of projects all with maybe similar groups of reasons, we can maybe look more strategically. Is there something that we need to be doing across the piece to try and address this? So we can maybe see about if there's a way that we can maybe present that in a more kind of coherent way. But that's what it's trying to show anyway.
Yeah, and thanks, Carl. That makes perfect sense when you describe it that way, and I get it would be a good, I guess, project management tool overall, just to give SLT and others just a sense of if there are any trends in terms of why things are maybe not progressing as planned. So again, and I wouldn't want you to do any more work on it. I think it's understanding what it's there for just helps me. So thank you. My final one, Martin, just with your indulgence, is on page 57, and it's just there's reference at the top of the page around identifying posts removed is difficult to identify 25, 26. I just wondered again if there's a reason for that particularly.
Oh, can help. Martin.
Yeah, thanks for the question. Yeah, so I think since then I've had a couple of meetings with finance, and first of all, there's evidence that the £1.34 million saving will be met in 25-26. We're also looking at reviewing the vacancy assessment protocol to just kind of provide assurance, I suppose, for finance colleagues that all the posts that are going through that process, there's enough evidence to suggest that the either that the posts have been removed, or that if the posts have been skill mixed and reviewed, that there's the budget is sustainable. And I suppose what I mean from that is maybe through the skill mix, there might be identification of a number of different cost codes to enable the skill mix to happen. And I think we just need to provide that assurance to finance colleagues that is happening. But also, I suppose we've got the evidence as well in terms of the forms through the vacancy assessment protocol that services provide. We can identify posts that have been approved through that. But I think it's just maybe just a little bit more evidence around the difference between posts that have been removed from the establishment rather than just being delayed by the vacancy assessment protocol. I hope that helps.
Yeah, thank you.
And thank you, John.
Thanks, Martin. Yeah, there's a couple of things on page 59 around PSIP and the GP visioning exercise. I just wanted to get a sense of how is general practice morale at this point, and if it's not high, what are we doing and what can we do to improve that?
Who can help with that question? Fiona.
So I'm going to ask Susie, put her on the spot. Susie, are you able to come in there? Thanks.
Susie.
That's a very big question, John. How is general practice morale as a whole? I mean, I think we're obviously heading into the winter period, so I would imagine all areas of the NHS are starting to feel more nervous. But I think the GP Vision has done a lot of good in terms of giving that direction of travel and aims and objectives, bringing everyone together in terms of what it is that everyone wants to achieve. So I think it has made a good impact.
We're also looking at moving into sort of better governance in terms of how we work better together across the 3 IJBs for primary care, and looking at our, I suppose, meeting structures. How do we do that better in terms of getting that decision making and getting, I suppose, a joint culture across the 3 areas, which I think will help greatly in terms of consistency, both for patients and for practices themselves.
Is there something that we can do as a board to help that position?
We're already doing a lot. I mean, we have obviously the cluster leads that we work with on a ongoing basis. So I think there's in terms of the IJB, I'm not sure as such, but in the background you'll be aware that we have lots of groups and works ongoing, where the practices can get involved. We meet with them on an annual basis with our practice visits. That's just been completed, and we're just away to have our report from that. My sense of what the feedback's been so far is that things are actually well. A lot of the practices are doing good in terms of recruitment and workforce. I think the demand on their time and like unscheduled care is still ongoing, but as a general sense of the fact, I think it's okay. In terms of what the board, that's such a big question. I would have to come back to you on that, John. I wouldn't want to commit to anything here.
No, get what you're saying. I'm just wondering if there's something that we could do in terms of publicity, PR. You know, people say, "Oh, I can't get it's difficult to get an appointment." Is there something that we should be doing to explain to the public what the issues are? And sorry, that's a feel free to come back to me on that when you've had a chance to consider it.
Yeah, there's obviously conversations at Scottish Government as well around things like that, with the discussions around the GP walk-in centres, etc. So yeah, I'll come back to you on that if that's okay, John.
Yeah. I mean,
Yeah,
I do
fine.
I do agree. I think that there is a lot more, shall we say, PR or marketing or just explanation to be given to the public. So I think it's a very important issue. It's about giving reassurance and supporting the public. Fiona, you'd like to come in?
Yeah, and I guess just thinking about the GP vision work, John, so we had a very positive workshop with a number of GP leads yesterday around about a primary care board. So transitioning from the GP vision work, because some of it's become business as usual, some of it we've had to part for various reasons. So a Grampian-wide primary care board is what we're looking to establish, and hopefully get our first one up and running before the end of the financial year is what we're working towards. So it was a really positive session with them, really engaged clinicians, and I think the value they can see with that board in place, John. So I'm happy to update as we progress with that. Thank you.
Thank you. Bernie?
I don't know whether this will help, John. Your question regarding how can the board help to increase awareness as regards what's going on, as regards the availability of GP appointments and all that. But during the last IJB CFO network meeting, which happened about 2.5 weeks ago, there's this discussion about this digital front door. I don't know whether you've heard of that before. This digital front door project being instigated by the Directorate of Health will go live with the Lanarkshire IJB, from what I gathered. And it started off with dermatology requirements or appointments. The objective of this digital front door basically is that going forward, most of our clients will go via this online appointments, ensuring that, because it's going to be national, that the relevant availability of GPs and doctors will be made available cross country. That's the objective, at least, so, but I like the fact that you're promoting the idea that, hey, how can the board help to move this forward? Yeah. I don't know whether that's relevant, but it's just something that I would like to share.
Yeah, no, that is helpful. Susie, you had your hand up temporarily, but then you took it down. Shall we move on?
That's fine. I was just going to
Yeah.
explain what Bernie was actually already
Okay.
said, so that's fine. She did it herself.
That's what I thought. Could I just I don't know if this is a comment or a question, but there's the table with the risks and mitigations, and referring back to our previous paper on test of change, quite a few of the risks are around pressures on staff, staff numbers, workload demands, quite excessive workload demands, and I mean I'm wondering. I mean this reimagining the solutions will require that creative effort to find new ways of working. I mean, it may be about a skills gap or reinventing how we deliver services and organize teams, because it's not really sustainable, not having sufficient workforce capacity to meet the rising health and social care needs. So I'm just have the feeling that for transformation, we're going to have to look at more tests of change. I think the community nurses is maybe an example of how we're able to take some of the pressures off of the professional teams. So that's just a kind of a comment, not really. Alison, you'd like to come in?
Yeah, thanks. If I can just comment on your comment,
Yes.
I think it's a lesson for us in planning for our next. We're just about to start planning what our next delivery plan, the year 2 delivery plan will look like. And obviously one of the first things we do is reflect on this year and what we've done and what we've managed to do. And we really did try this year to match our ambitions to the resources, but things change as you go through the year. So I think we'll be really mindful when we're planning what activity we're doing for year 2. We need to achieve what we need to achieve, but we need to be mindful of the resources that we've got and the existing pressures that are on the staff at the minute. So yeah, a good observation there. And as I say, we have not noted it, and we'll do what we can to try and make next year's a bit more manageable.
Thank you very much. Obviously, the delivery plan is an evolving document, and I think it's being entered into and dealt with with a positive spirit. I mean, there are a lot of pressures, but I think that there is a very constructive attitude in trying to find, the really helpful solutions. So thanks very much for that response. Recommendations are on page 45. Are we content to agree those as a committee? Yes, that's agreed. Can I just pause for 2 minutes because I have to get the charger from my laptop. So could we just have a 2-minute recess and I will be right back. Sorry about that. Right. Three. 2. So are we back?
I suspect that was a speed comfort break, Martin.
I know. I did say two minutes, but people are coming. We're repopulating. Three. That's 4.3. Right. Right, sorry about that pause. So welcome back, everyone. We're now on item 4.3, which is the Justice Social Work Performance Report 24-25. Val and Claire, I think, are involved in this. Are there any introductory comments to introduce this?
Thank you, Chair, and morning, everybody, and just happy to give a very brief overview. So I'm pleased to present our Justice Social Work Service annual performance report for 2024-25. This is really for assurance purposes, in line with the terms of reference of the committee. It's not a statutory report in any way, it's for internal reporting purposes, really. You'll be able to see by the report that has been a challenging year in common with services across the piece. Demands have continued to increase in terms of our kind of bread and butter. So report requests from court, numbers of community orders imposed, and numbers on statutory license and release from custody. We see also a kind of increased complexity of those who are kind of coming through the door as our clients, and there's all the kind of background legislative changes in guidance, all that kind of thing that's pretty much ongoing for our service. The report sets out some kind of specific challenges that we've seen and continue to address, really. For example, unplanned liberations from court, improving the pathways for young people, the early release from prison you'll be aware of. We keep seeing waves of that that we're kind of working with and involved in. Despite that, or in the report, it reflects some of the really positive feedback we've received from clients via our questionnaires, which is really kind of obviously we share that with staff, and it's really kind of helps people to cope. Also, just a little bit of feedback from the beneficiaries of our unpaid work. Again, really positive there. The report also reflects areas where we're focusing particular improvement work as part of our refreshed delivery plan for the period 2025 to 29, including some looking to improve some of our collaborative working with partners, including housing, mental health. We're close to completing our lower level domestic abuse programme to start looking at delivering that. We're improving how the expertise of staff in how we work with people with alcohol and drugs issues. There's always lots of changes to kind of respond to in the background at the same time. Yeah, and not least of which establishing a new team to deliver the kind of sex offender programme, which people is imposed as part of a community payback order requirement from 2026, as the Shire have they're withdrawing that service. So we're kind of creating a new team with the money we would have paid the Shire to deliver that programme in-house from April. So it's been a tough year. We're still getting positive outcomes, and hopefully the report reflects that. Claire, I don't know whether you want to kind of add anything to that from your perspective.
Yeah, I suppose just to add it, and as Val says, it has been a challenging year, and you can see in the report the increase. We're also doing a lot of work in terms of increasing our bail supervision and trying to reduce our demand numbers, which we'll continue to do. Our diversions, we've got a really good rate for diversions, one of the best in Scotland. One of the things I just wanted to add was in terms of the funding formula. So it's a ring fence budget we get for justice. Sometimes is a good thing and sometimes not. So so the money we have to spend on justice. So there is a new funding formula which has meant that we've got a slight increase in funding because of all the new initiatives, because basically the funding works that we get money for what we deliver. So that's why we've got such a lot of statutory reporting, because we're then paid for what we're delivering in our figures. So different funding formula, a bit more money. So what we need to do now is actually to make sure that we've got the staff in place to meet this demand, and more demand will come in with the focus on the community supervision and that whole drive of keeping people out of prison. That comes at a price for us. We just need to make sure that we've got the staff in place, because it's public protection at the end of the day. We need to supervise these offenders. So we are looking at increasing. In one hand, we're looking at efficiencies of staffing across the partnership, but in justice, it's going to be the opposite. We're actually going to have to establish more posts with our additional funding in order to meet this increased demand, and obviously ask that we've got from government. So that's one of the things. So just to add that in, but yes, I'm happy to take any questions on the report.
Thank you very much. I mean, I was going to ask about the impacts of early release on the service, and you've given an understanding of that. And I mean, I'm just wondering if that's sustainable. Early release is large numbers of new clients coming into the system.
It is, Martin, and as you know, they've done this several times. We're kind of into a very good routine now. We've got a very good multidisciplinary group that works on that. We look to see, because we've obviously got prisoners right across every estate in Scotland. So we look to see, what is the implications for us. It is a bit more work. However, I would say that if prisoners are non-statutory prisoners, so those who aren't on licence when they come out, in a way, it's kind of a good thing, because we manage to give that real wraparound targeted support when people are coming out. Sometimes if other people are coming out just through the normal route, they might not take up the offer of voluntary aftercare. So actually getting in early, providing that wraparound support is good. The numbers, I think we've had 5 released so far, Val, and I don't know if you know off the top of your head, because we do map to see, right, every time they do it, how much, what's the figure, what's the impact on city.
Yeah.
I don't know what the full figure is, Val, if we know that yet in terms of the criteria.
No, we don't. It's an ever evolving picture.
Yeah.
Each week we get a new list of people who the service is one of the partners that is asked to kind of make any comments in relation to vetoing their release, to kind of contribute to the governors making that decision, the prison governors. So I can, it's definitely 5 for the first week, but there's different tranches in this bracket. So we will have a final figure at the end of the day, but it's quite hard to pin down.
So a lot of work, and we are working with the sheriffs, Martin, in terms of, because we've got the presumption against short sentences, so people shouldn't really still be going into prison on short sentences, but they are. So that we still have a lot of work that we're doing on a national and local level, working with the sheriffs to try and avoid them going into prison and keep prison only for those who are at risk of to the public. So huge bits of work, but we're managing, and it's a collective responsibility. So we work closely with housing, we work with the prison estate, and as Val says, we do the checks and balances, so we can go back to the governor of the prison and say, actually, we have got intelligence, or we think this is a risk letting this person out. So we do have that ability to stop.
Okay, well, that's good. So the number, so five.
Five so
do,
far.
Do the numbers fluctuate much, or is it broadly within that, within a kind of a lowish, manageable
No, that's just
number?
been 5 in a week. So
Yeah.
if there's going to be much, I mean, Val, what was the total numbers we had the last time they did the early release?
It wasn't that high, Claire. Gosh, I'd have to check back.
Yeah, I mean, I'm just wondering if there's a kind of a stability in the numbers coming into the social care system, or I mean, it's not suddenly large volumes.
No. And they do it in tranches, so
Okay,
it's very slow.
Yeah.
So it's a kind of drip feeding of release. It's not just 50 people will pile into the city. So it's at least we've got time to prepare and plan when they do it in tranches. So it's good. It's manageable.
Yeah, that's great. Thanks. Richie.
Don't really have a question anymore. I think Claire kind of answered the one I was going to have around, I guess, new responsibilities and funding. But otherwise, just as I thought the report was really good. It set out the kind of picture really clearly. Obviously, a lot of challenges there to set out, but it's a very well managed service, looks like. So, no, just a thank you and well done. Thank you.
Grand. I think there's particularly helpful information on unpaid work, on those alternative solutions. I mean, are there evaluations done of the impacts? I mean, I would presume that there are some really positive results for all involved. And I think there was a mention that it's increasing the volume of unpaid work. So it is a preferable alternative penalty.
And that is one of the areas, Martin, and we do a lot of evaluation and we know the impact and stuff, and the unpaid work and the increase in unpaid work, it has been a bit of a challenge. And I think the last time we came here, we spoke about after COVID, we had a reduction of individual placements. So it's something that we're really having to look at this year to say what's alternative options for unpaid work placements, because we only have so many task supervisors and so many hours that we can do in a week. So if you've got a significant increase, it's really difficult for us to undertake that hours. So we are, and I chaired the performance management board, and it's something we spoke about the other day, is what is our options for widening out the chances for people to do their unpaid work. So it's definitely something we've had to look at, because it's increased 34%, which is significant. And it's not small amount of hours, it's significant chunks of hours that people are getting. So we need to make, because they're only given a time limit by the court to complete their hours within that time frame. So it is a constant challenge to make sure that people can complete their hours within the time, or we have to write to court and tell them why not. So but it's something that we definitely need to look at. If it continues to increase, we need to really think of different ways we can help people do their unpaid work.
Okay.
Thank you.
Thank you. I mean, I think the activities and the outcomes are very positive overall. So it's an important and valued area of work. So thank you very much. So we turn to the recommendations. I mean, are we content with the recommendations? Before we close on that item, I believe, Claire, this is your last visit to our committee.
It is.
So I just wanted to say thank you on behalf of the committee for all of your help and support, for your professionalism. It's very much appreciated. Thank you. And we wish you all the best. I think we will see you at the IJB, but I think this is a welcome opportunity for the committee to say thank you and best wishes. So
Thanks,
thank you,
Martin.
Claire.
You'll make me cry. Thank you.
Thank you. Right. So that is, and thank you, Val, also for the report and for the feedback. That takes us to an end of 4.3. So thank you all. We can move on to 5.1, I think, is our next item. which is the Q2 report, budget report. Bernie, any introductory comments, or should we just open it to questions?
Yeah, I would welcome questions at this point.
Okay. Members, any questions on this report? Richie?
Yeah, thanks, Bernie, for the paper, and two or three things just for clarification, really, again. And again, I think overall still a pretty positive picture in terms of the bottom line. So again, a big thumbs up to all concerns thus far. I appreciate this is just the end of Q2, so we've still got some time to go, but nonetheless, it'd be wrong not to recognise some good work done to date. Questions are around just some of the variances, and I think I should describe it unfavourable variances. And I know that there's a part of the report that talks about mitigations and mitigating actions and such like, but I wonder if there's any more specific mitigations against those areas that are particularly unfavourable in terms of variances. So I guess for me, in terms of assurance, it would be, are there things, are there actions, is there activity around those particular budget lines and service areas that has been undertaken to mitigate as far as possible those pressures? And I appreciate, I guess a lot of them will be around demand pressures, but nonetheless, I think something a bit more specific in terms of those areas would be helpful, I think, for the committee to, I guess, to get underneath that a little bit more.
Okay, I'll start off, and then possibly maybe Fiona and Claire and even Martin and Sandy can add in a few points. But I would just like to reiterate that on a regular basis, I believe every fortnight, we have a budget savings oversight group that goes through and discuss in minute detail all the savings option we have set out from the very beginning, and even working on other additional savings options we're going to have in the future, in the next fiscal year, and of course, towards maybe additional 2-3 years. On top of that, we are actively meeting with our counterparts in NHS Grampian on a fortnightly basis as well. We are actually meeting with the NHSG Director of Finance to discuss further what the challenges are. We all recognize, I think the real challenge is the limited funding from government and from the health authorities. Our objective stays the same in terms of we wish to deliver on quality care. So it's just working around the limited funding and what we can prioritize. And this is where the input from the service team headed by Fiona is really absolutely vital. So inputs from Fiona and the rest of the team can be very helpful. Fiona, perhaps maybe can start.
Yeah, so very happy to come in, and thanks for the question, Richie. I think we're seeing there's kind of two main areas that are giving us financial challenge. So our prescribing budget. Now, I'm sure, well, the year before there was 6 million moved from adult social care, which was always our biggest risk area, into prescribing budget, which gave us a really nice balanced budget. And we actually had an underspend in prescribing last year. And then earlier on this year, we agreed to move that 6 million back because of the financial risk to adult social care. So we didn't put any additional money into prescribing this year, which is why we're seeing that significant overspend. So the other Grampian and Health and Social Care Partnerships our IGBs did put some additional, they did shift some money and put it into prescribing. So we're definitely doing some work on our prescribing budgets. Some of that's quite difficult because some of it's completely out with our control, but there's obviously NHS Grampian are looking at this as well, and we're around that. But some of this is completely out with our control because of licensing and all the rest of it, and costs that come in. And there's been all the unsettledness in America that's also contributed to the increased costs of medicines. So it's certainly an area that we know of. We're working with Caroline as well, our medical lead, to make sure that the prescribers are aware of the financial risks and our pressures. And there will be another national campaign. There was a national campaign last year about being really thoughtful about repeat prescriptions and stuff, and that's going to happen again this year. Our other big pressure is learning disabilities and mental health. We're going to actually do a deep dive at our next insight session on that, just to give you some of that more detail, operational detail, maybe that we don't normally take into the committees. I think you can see Claire's team in the older adult services is actually underspending, and we're having that conversation about, do we need to move some money to balance that out? Because I think that, as you say, that demand for services is increasing, and we're certainly seeing a significant increase in learning disability and mental health. There's also our medical locum is an added pressure as well, and we've been absolutely doing some work with Alistair Pale and the medical lead to try and reduce that. Psychiatry has been a significant area of challenge for recruitment. The next 18 months is looking a much better picture if the people that are in the training positions at the minute due to stay with us. We're not supposed to ask them, but we have had a very quiet conversation and they are keen to stay. So that will, in the next 18 months, we'll continue to see that locum reduction, hopefully, coming through, which will also help us because they're a much more expensive model than our own existing staff. And we also have seen an increase in the number of people that have been requiring detox. And unfortunately, we don't have a service in Aberdeen City for that. It's so we have to put people out of area. Now that can be to Aberdeenshire and also Tayside. But that's another financial pressure this year that we've seen an increase in. So lots of work happening to understand. And some of it's in our control, some of it's not in our control, but thankfully some of our other areas are underspending, and that will help us overall, that balance. Richie, does that help, Richie?
It absolutely does, Fiona, thanks. Yeah, I guess it's just that not look for chapter and verse from the reports, but it might just be handy to have some of that in the mitigating bit, rather than kind of being too general, just being a bit more specific in terms of those areas that are experiencing some pressure. And I was certain that there was lots of activity underway behind the scenes, but it's just, I guess, teasing it out so it's, as a committee, we can be assured, I guess, that's actually actively underway. And you've touched on actually the kind of second point is around the underspend area, and again, as you say, you're on top of that as well in terms of understanding if that's going to be sustained, how that fits, that helps us balance the books. The worry would be, I guess, if that wasn't there, then we'd be in a bit of trouble potentially. So, and I know that then impacts on the MTFS and the future planning and such like. So I get that. So I know that. I think I'm assured by all that. My final question, Martin, is just around the additional NHS Grampian funding. And appreciate that's going to come in year, and it'll be for particular purposes. And I hope it's not too clunky a question. How will that, if any, if at all, impact on our own IJB budget in terms of where we're at just now? Does that help, hinder, or is it just complementary? So just any kind of comments on that additional NHS Grampian funding and how that impacts on our budget would be helpful. Thanks.
I can answer that first, Fiona, and then maybe you can help out. Okay, we've been in discussion with the NHS Grampian team as regards this additional funding, about 6.7 million. But for the purpose of our report, the one that we have presented to you in this RAPC meeting, that 6.7 has been considered already. And this is the reason why we're mindful of the fact that what I call the bailout money of 10.9 million, 4.2 coming from the council and 6.7 coming from the NHS Grampian, has been considered in the calculation of our Q2 results that led us to an underspend of 44K. This is where we have to emphasize the point that should that additional funding not be there, then we are in an overspend position. This is the reason why we're perpetually and continuously finding additional savings options. Now, just to add into what Fiona said a while ago regarding prescribing areas being out with our control, just to give you a very specific example, just to be on the nitty-gritty side of things, you try to get a doctor's appointment, say for a simple pain on your backside, and then they will try to schedule you an appointment with a physiotherapist. In the meantime, they give you a prescription medication, without even seeing you first. Yeah. So in relation to what John said a while ago, how can the board help in this instance? I think, how do you educate the GPs? It's the first question that I have to put through. So yeah, I mean, from within the group, we try and find all the possible savings options there might be. But if the GPs themselves prescribe, as an example, without even seeing the patients, there you go then. That's an example of an out with our area control over the expenses, if you know what I mean. Fiona, if you can
Thank you.
add something.
I think Fiona wishes to come in.
Yeah, thanks. And yeah, so I think there is lots of work happening with GPs, and I think it's trying to understand that system, Bernie. So, but yeah, I think, Richie, are you referring to the unscheduled care money that we've got in? Yeah, so the unscheduled care bid that we've got in, so we have got some money. So the first tranche of money, we have got some additional, we've purchased some interim care beds. So we've purchased 4 across the city. So we're doing that and using that money. So we're absolutely involved in the conversations and the opportunities that are there. Neil Gray stood up last week in Parliament and said there's another £20 million coming for social care. We've not had anything formal through about that yet, Richie, but hopefully that will give us another opportunity. And I think we very much welcome that opportunity for, rather than just everything being focused on the NHS side, because a significant pressure is on our social care. So really welcome that. Don't know what that's going to look like locally yet, but we will absolutely be all over that and getting what we can to improve services. I think it's that balance, though, when we're looking at savings and what are we doing to services, and then we've got new money coming in, and I think we're very mindful about making sure we do the right thing with the money, and we're not just filling a bit of a hole. So I think and I think the government are very clear, they want to see an impact. So I think it's that real balance at the minute. But yes, we've got some money, and we've also got, because of the geriatricians that we spoke about earlier, we now have a geriatrician in A&E 5 days a week. And that's again with the unscheduled care bid. So that money, and that's been really closely monitored. So the NHS Grampian are holding that money, Richie, and they're just passporting through. As we spend money, they put it through. So that resource transfer is all in place. Does that help, Richie?
Yeah, no, great. Thanks both. And sorry, Bernie, my question wasn't clear enough. So
My
no,
apologies,
that's fine.
yeah,
Thank you.
for misunderstanding as well.
No, no, okay.
Sandy, are you coming in on this very point?
It was to try to give sort of general assurance as Bernie kind of asked people to jump in. So it was really just a couple of things I thought I might add. One would be, since the last meeting of this committee, the partnership and collaboration with ACC have appointed a deputy CFO. And it's probably worth just highlighting that at the committee, because that has a significant component in our day-to-day operation and assurance process. And I think the other thing that struck me was, and you could relate this to a number of things in the current financial year, we're just at the start of the public budget consultation process. One of the things I think it helps is it allows us to point to something in the future that we're already doing just now, and that things need to change. So I think it does have those kind of, so for example, premises reductions is an example. We're doing that in the future. It helps us allow to do that now. I think it was just to add that to try to provide some additional assurance to support Fiona.
Okay. Thank you very much. On to Hussein now.
Thank you very much, Chair, and thank you, Bernie, for the report. I've got 2 questions, and I will caveat the first one by saying I apologise if I have misinterpreted or misread this. But there seems to be a statement somewhere in the report that said, and forgive me because I don't have the exact wording to hand, but it's something about unexpected demand on transition to adult services, or unforeseen demand on adult services coming in from children's services to adult services. And it led me to wonder, in terms of demand, in terms of demand planning for what is currently in other parts of the system, are we able to do that in terms of our budget planning for the coming year? So we know what, appreciate there may be people that maybe come in towards the very upper range of the child services, maybe people who are moving in from out of area, for example, that we perhaps don't have a handle on. But for those who we currently do, who are receiving support, are we able to track the very likely progress that they will then require support from adult services and incorporate that into our budget planning? I just wondered if there was some narrative as to where the kind of unforeseen bit came in, And apologies if I'm misreading that. And I've got one other question, Chair, afterwards.
Okay. I think Fiona and Claire wish to come in.
Yeah, thank you. Oh,
No,
sorry.
you go first. You go first, Fiona, and I'll mop up at the end.
So I think I'm sure it's coming to the IJB in my paper about our transition. So we've done a lot of work, Hussein, on this because I think there wasn't that great oversight. So I think that's added. Some of it is, as you say, it's people out of area coming in. So yeah, we don't have that awareness until they're here. And there is that some people want to be nearer the hospital, so they move to city from different bits of Grampian as children get older, and because they want to be nearer the hospital. So I think that's one of the challenges that we've got. So we've believed they were going to be in a different part of the system that we are not responsible for. So I think that work, and hopefully it, as I say, at the IGB, that transition paper will give that assurance that we've done a lot of work to improve. So we have that much greater oversight than we've had historically. The same. But Claire, I don't know if there's anything further you want to add.
Yeah, just to add into that. So we did used to look at what was coming up from children's social work, looking at kind of 5 years in advance. We could do a lot better in terms of the costing of that. I think where the difficulty has been is some of the people are coming from education who are not necessarily open to children's social work. So we're getting them through education as well, and we've not known about them. So there has been a joint piece of work going on all year about really mapping out the needs. And we're seeing that people, because they're also coming from health services into the community. So whereas the paediatric team would be looking after them, they're now coming into social care side of things as they come to adults. So I think it's just been a perfect storm. So the number that has coming through are increasing because people are living longer with very complex needs where we wouldn't have seen that before. So I think it's a perfect storm, and it has just increased every year. So, and I think there is such large numbers coming through this year through NHS, through children's social work, and through education, and that's why we're seeing a bit of this pressure.
Thank you very much, both. That's really helpful. My second question was more of a technical question regarding the apportioning of funding between our partners, NHS Grampian and the council. And it again, I didn't access last year's budget report to compare, but are the proportions roughly static or do they change? Because I just, something in my mind just tweaks that the apportioning figures were slightly different in the previous year. Is that based on some sort of variable formula, or is the split hard coded, so to speak?
Bernie?
Maybe this is something that Fiona can support me on, but the IJB in itself has got what we call an integration scheme that sort of like generically defines the split of the funding between the Grampian, in our case, and the Aberdeen City Council. On average, during the past year-on-year sort of like split, it ranges from NHS about 60 to 64%, and then from the council, the balance of the 100%. Okay. So, but if there were any changes, I don't know whether Fiona can add some more information regarding that, as regards if there's any official documentation or advisory.
So Bernie, I wonder if it's more about the set aside, because that does fluctuate.
Is that the set aside or the funding itself?
So I think it's the set aside that seems, so the funding doesn't change that much, Hussein. From our medium-term financial framework, it might go up a little bit. And that all depends on what comes through real living wage and all of that. But the set aside, it does fluctuate, Bernie. So I don't know if you can explain a little bit about why the set aside fluctuates like it does.
I believe on the set aside, I mean, there's only two elements of the set aside. One is the housing element coming from the council, basically to support the care homes. That's steady at about 1.7, 1.8 million pounds year on year. The set aside, on the other hand, from the NHS, last year it was about 55. This year it went up to 59, and that basically pertains to hospital care provision, that sort of thing. How I will need to check on this one and get back to you on this one, Hussein, how the NHS comes up with the calculation of their set aside. I'm not really very familiar with, but in terms of the housing set aside coming from the council, that is of course considered along with the housing revenue, housing funding budget. I can get back to you as regards the NHS set aside calculation, if you may.
Thank you. And as I say, it's not a showstopper and it's not urgent, but it was just a curiosity as to whether there was that variation. And it sounds like that generally the proportions are static, but there is, there will be a little bit of swing, very minor below percentage points one way or the other.
Yeah, valid point. Yeah, thank you.
Thanks very much.
That one. Yeah.
Yeah, it does seem to be something of an art. It's the proportionality is mentioned at 5.1, and yeah, it is a bit puzzling. So thank you for that. John.
Yeah, thanks, Martin. Just on the last point, my understanding has been that it's always been roughly 60-40, with a wee bit of tweak here and there. I was just going to make an anecdotal point, which is that I got a same-day appointment with an excellent physio at the Elm Bank surgery for my dodgy back the other day, despite the fact that I'm still having lots of painkillers. But you can actually get same-day appointments if need be.
Okay, grand. Thanks for that. So thank you, Bernie, for the Q2 update. I think it's very reassuring that the outturn is close to budget, and I think that, as was mentioned, it is a result of the very close collaboration with the council and with NHS, with the additional support, and I think that's just an example of the strong partnership working that we share, because we care about the health and social care partnership. Yeah, and I think it's great that we've got you on board, Bernie. So good that we've got a deputy chief finance officer in place as well. So thank you. Can we agree the recommendations for 5.1? The committee's happy with the recommendations there? Yes, grand. Let's move on then to 5.2, the directions report, which is from Alison.
Yes, thanks, Martin.
Thank you, Alison.
Thanks. So this is just your routine six-monthly report on both directions and DPIAs. We're kind of getting into the swing, certainly with the directions. We're kind of getting into the swing of this report now. You may recall that we had new guidance issued towards the end of last year, so that's really helped us with the preparation of that report as well. And we took some time to reflect. So we did a little bit of an audit of the directions in their entirety, and that picked up a couple of omissions from previous reports. So I have to apologise for that, but we've hopefully captured them all now, and they're all reported within the report that you've got there. We are planning to do the same with the DPIAs. That was very new for us, and we were we've been trying really hard to make sure that we've got all of the relevant information. So we're going to sit down with the two data protection officers, one from Aberdeen City Council and one from NHS Grampian, and just do a bit of a full review and a bit of an audit around about that as well. So we'll report on that for our next 6-monthly report. But in terms of the directions themselves, there's no reds. 77.4% are either green, which is on track and not due for renewal, or grey, which is complete. with the remaining, the 22.6% are amber. And as you can see from the report, there's plans in place for all of those ambers within their timescales. So that's as much as I think I need to say about the report. Happy to take any queries or questions.
Okay, thank you very much. It's good to see that very comprehensive structure for the directions and the updating. I think it's interesting to note that there's varying scales of action, effort, resource budget for each one. For example, the shifting the balance of care is a very considerable undertaking. It's good to see that there's a plan there to deal with that. I wanted to ask about the DPIA list. Is that on page 109? Is that a list of all areas which are relevant to data protection, or is it a selective list, if that makes sense?
So it's a list of all data protection impact assessments that have been raised in relation to business that the IJB is directing, basically. So if we've taken a decision to do something and that particular piece of work needs a data protection impact assessment, then that's raised. It goes to the relevant data protection officer, whether that's in ACC or NHS Grampian, depending on the work that's being done, and they approve that or not. So it's just a record there to make sure that we are recording that and tracking them as well, so that we know that if a data protection impact assessment is required, that it has been done. So you'll see that a couple of them, where we've raised data protection impact assessments, the work is maybe on hold, but we've got the data protection impact assessment there just in case we need to raise that again. We would probably need to update and revise the data DPIA, sorry, trying to get my teeth around that. We'd probably need to update DPIAs if we resurrect some of that work. But yeah, it's just trying to keep a track. One of the things that we are going to be discussing with our data protection officer for NHS Grampian in particular is whether we should have system-wide DPIAs recorded here. We have restricted the list to only the data protection work that's relevant to the city. But there are, particularly with primary care, there's lots of additional data protection impact assessments, but it's relevant to Grampian-wide work. So we had a little bit of a debate around about that in the preparation of this report, and we didn't come to a conclusion. So that's going to be part of the audit and part of the discussion with the data protection officers, just around what is relevant for this committee to see.
Okay, thank you. I imagine that you'd want to focus on Aberdeen City Health and Social Care Partnership, but that will be considered in due course. Thank you very much for that. Any questions on 5.2? I think it's all very straightforward, very clear. Nope. Can we agree the recommendations for 5.2? All agreed. Thank you very much, Alison, to you and your colleagues for 5.2 for the directions work. Thank you. 6.1 is the strategic risk register, led by Martin.
Yeah, thanks, Chair. So the report in front of the committee provides an updated version of the IJB's strategic risk register. Members will recall that the risk register template was revised ahead of being reported to the IJB in July, and this was explained to members at an insight session in June. So I really just want to focus on the kind of main changes to the risk register this cycle. And they relate to two risks. The first one is risk 2, which is the financial sustainability risk, where we've added additional mitigations around developing a financial sustainability assurance map, but also want to highlight that having reviewed the risk with the Chief Officer and the Interim Deputy Chief Financial Finance Officer, has been agreed that the risk scoring for this risk remain at 25, but this scoring will be reviewed in detail once Q3 financial results are published. And the other main change relates to risk 7, which is the staffing risk, where the cause, event and consequence of the risk have been reworded to reflect the details in the strategic plan and the medium-term financial framework. The updated version of the strategic risk register forms the appendix to the report. The risk owners are in attendance if there are any specific questions or comments. Thank you.
Okay, thank you very much. I think it's really good to see the ongoing intensive focus on particularly well, especially risk 2, also risk 7, and it's really good that there's that very strong ongoing work amongst yourself, Martin, and colleagues to tackle the challenges of financial sustainability, because they are huge. So yeah, it's comforting that it's in hand, that the work is in hand to mitigate as far as possible. So thank you for that. Richie?
Yeah, just briefly, not for the question as such, and I think the explanation in the covering report I think was fine in terms of where we're at, so I can understand the nature of the changes to those two areas. And if we review the financial one in due course, then that's fine. But I think we're being prudent, just keeping it as it is just at the minute.
Yeah. Okay. Can we agree the recommendations for the risks for the strategic risk register? Committee happy with that? Yes, good. Thank you very much, Martin. On to 7.1, prescribing efficiencies report from Susie Downey. Susie, did you want to make some comments at the start, or just go to questions, or what's your
I can
preference?
happily just give a quick introduction, or
Yes,
I'm happy
please.
to do questions, whatever you'd like.
Introduction would be great. Yeah, yes, please.
Okay, no problem. Basically, this report gives an update to the committee on the prescribing efficiencies within Aberdeen City. The key parts to mention is that this is part of a wider efficiencies programme as part of NHS Grampian Pharmacy and Medicines Management and their performance reporting. The report gives you some background information and context around the spend on things like key pressures such as rising medicine costs and the increased demands from patient need, as well as the impact of the national policies such as the Scottish Drug Tariff and other things such as the Pharmacy First and Pharmacy First Plus, and gives you a bit of context and background to that. The report gives you an update on the efficiency work that's being undertaken. The city's working closely with the other IGABs and the medicines management team to look at a plethora of different activities and efficiency activities. The report hopefully can outline to you that it's a large and complex budget, and it takes up a lot of is made up of a lot of different activities. So it's clear that there's not really just one key fix. It's a lot of different pieces of work that's looking at this, and the report summarises all of them. We've noted things like public engagement and consultation, and working closely with our clinicians, our GP colleagues, to reduce the spend and the things that we do have within our control. But I'm happy to take any questions, but hopefully it gives the committee the information it needs.
Yep, thank you very much, Susie. I mean, I've got a kind of a basic question: is what can the committee, what can the IGB do? The overspend in 25-26, 2.9 million. 95% of prescribing decision making is made by GPs. So I think the point was made earlier. How can we try and influence the prescribing habits or customs or whatever? I mean, there's some really good key campaign messages at 4.18, which just seem good advice about only order what you need. I mean, this is for the public. Check your pharmacy bag, return unused medicines. But there's probably some awareness raising or some adjustment of expectations amongst patients and particularly the GPs as the main prescribers. So it's kind of an open question. What can we do to try and influence the spend, I suppose?
Yeah, and you see it in the report. A lot of it is around public expectations. So the public campaign is actually underway, so you'll see that in social media. So please share that as widely as you can and share any information you can with the public. That helps. People do read these things, and we've got posters up on the back of bathrooms and in practices to support that. And actually, I think the campaign people do understand it. It's just difficult in the moment when, if you're being offered a prescription, to know just little things about ordering and things like that make a huge difference to the prescription budget, because it's made up of so many different things. You mentioned working with our GP colleagues. You're absolutely right that it's 95% of our prescribing, and it's very much patient need led, and it's done on a clinical basis. So it is tricky. We have done some sessions with our GPs in the city on an ongoing basis, which Caroline Howarth on the call, she's actually led this work. And we're also working closely with our GP cluster leads, looking at kind of sharing that information and looking at like moving to like non-branded products, things like that, and switches that make no difference to patient outcomes. It's just actually maybe a branded version to a non-branded version. And I think mostly practices and GPs are receptive to that. They understand that, but it comes within an already busy system. And also you have to bear in mind that this isn't their budget, that this is the IJB budget. So it's a really tricky thing to balance. I don't know, Caroline, do you want to come in the back of that?
Yeah, I mean, you've covered quite a lot already, Susie. Put my hand up before you said that. So yeah, and I guess a couple of things I want to say. 95% of prescriptions are in GP practices, but remember, it isn't just GPs that are doing the prescribing. We've got our many non-medical prescribers, because we have employed lots more non-medical clinicians. Susie's right. It isn't the practice's budget. We have our own budgets, which are incredibly difficult to manage at the moment because of increasing costs. So obviously, trying to get my GP colleagues on board is very difficult. I'm not pushing against an open door. I'm pushing against a very batten down the hatches door. So for them to commit to additional work without any additional benefit for them running a business is incredibly difficult. That doesn't mean they don't want to do it. They absolutely know it's the right thing to do, and they will pride themselves on prescribing efficiently and correctly. So I think yesterday we were speaking to Director of Pharmacy, about what could we do, what could we make a massive difference. So I'll give you the example he gave us, which I think is quite a good sort of context. So forgive me for my numbers, but roughly we spend over £1 million on PPIs. You'll know them as omeprazole, heartburn treatment, right? About 140,000 patients in Grampian, and he only gave me Grampian figures, by the way. So about 140,000 patients are on Losec, PPIs, omeprazole. It's not an expensive drug, but there's so many people on it that it's a very expensive in its entirety. About 80,000 of those people are on it probably because of lifestyle. So the others are on it because they're taking something like ibuprofen. So we protect people's tummies when they're on something like that. So you can totally justify giving someone that. But you could argue that the other 80,000 patients are on it because they are not living their best life. They may be overweight, they may be smoking, they may be drinking too much, they may be eating too late at night. All these things, and these drugs work wonders. They are fantastic. In order for us to save millions of pounds, are we able to say to patients, well, you're not getting that anymore? Now, GPs would do that, but can you imagine how difficult that would be for the GPs to have that conversation? Look, the sheer volume of patients, but also these difficult conversations, they take so long. So I think I'm very good actually when I'm triaging patients, and I'll say, no, you buy the paracetamol, you buy your antihistamine, you buy your laxatives, but the arguments come, and then the fights come, and then the complaint letters come. So this, I'm just giving you this for context because it seems really easy. We'll just stop doing this, but for the people that are actually having the conversations and at the coal face doing these things, we need a much higher level decision in terms of, right, we are not going to do this anymore. For some of these things, the medicines management team in Grampian are absolutely fantastic. They have done such an amazing job at picking out where we can get the biggest bang for our buck. So the examples that Susie's got in the paper, changing different medications to branded medications, or even just from one generic drug to another generic drug, they've all happened. Mostly practices have engaged in that, or we've got a central team that have come in and done it, and they have made significant differences. Recently, we've just started sharing prescribing data to cluster level, and that breaks down, so GPs don't like to be an outlier. So if I can bet your bottom dollar when they start, and this is only just in the last few weeks, when they see that they're an outlier, they'll be like, oh my goodness, I don't want to be that practice. Let's have a look. But it's slowly catch a monkey, to quote someone. It takes time, because each one of these changes is a patient conversation, and a difficult one that takes time in an already very stretched service. So the willingness is there, the capacity probably less so. I could probably speak a lot more about it, but hopefully that gives you a flavour of the kind of conversations that we're having to have actually with the patients and the people actually that you're asking to do this, make this change.
There's a bigger picture about behavioural changes, about prevention, and the role of the pharmacology in all of this. So thanks very much for that. John.
Yeah, thanks, Martin. Just a couple of comments. When we're looking at prescribing costs, I don't think we should look at it in isolation. We should do what we should always do, which is to look at a whole system. And I'm old enough to remember the 1990s, I think, when there was a huge increase in prescribing costs for asthma medicines. And it actually stopped people having to go to hospital with acute asthma attacks. So the prescribing cost went up, but the overall system cost went down because you weren't having to have people in hospital. So I just think we need to be, we need to take a whole system approach. And increasing prescribing costs is not necessarily a bad thing. It might be if we're not using sufficient generics, if we're continuing to prescribe drugs of limited clinical value, that's a bad thing. But if you're using stuff that helps to support the whole system, that's potentially a good thing. Just a thought.
Very true. Thank you. Richie.
Yeah, again, thanks for the paper. And just as an aside, Carolyn, your example about omeprazole was incredibly interesting, and just a real maybe description of the dilemmas that are before us in terms of this kind of area. But just for today's purpose, I'm assuming that the trends in the Grampian are no different to the trends in other parts of the country in terms of prescribing activity. Just first and foremost, I'm seeing nods. That's fine. I just making sure we're not an outlier in any way. And the other thing, this is maybe more on for NHSG colleagues separately. There's mention in the paper about pharmacies that are under financial strain, and I just wondered, without getting into details, how do we know that? How is that monitored, and is there any activity in the background to try and manage that to, I guess, mitigate against pharmacies really struggling or potentially being threatened?
Susie.
So so I'll pick that up. So it's similar to all independent practices, similar to GPs, they're independent businesses. And as already mentioned, the costs are rising, energy costs, bills, etc. It is managed both nationally and locally in terms of SLAs, but similar to any independent, it's the consideration of the different service level agreements and how much they cost, whether they pick up certain pieces of work. Is it worth their time to pick up certain pieces of work, things like MAR charts, things like that, renegotiation of those costs with the board. So that potentially could increase our costs. But again, thinking about patient need, and thinking whole system, is that actually a good investment, an investment we should be doing? Also things like I mentioned about the Scottish drug tariff, that's an example of that those costs are not passed on to the practices, the pharmacies, but that is something that we then pick up the gross cost, sorry. So that's the sort of thing that's managed both nationally and at board level. But again, it is a national issue. This is not local to us.
Grand. Thank you. Next is Hussein.
Thank you very much, Chair. John has spurred me to ask a question, as he usually does. He's got me thinking. Just in terms of the data, and you mentioned in your introduction there about, you mentioned starting to get cluster level data. There's a lot of interventions that are mentioned in the paper around behavior change. And I guess my question is, do we have sufficient data, albeit with the relevant data protection? I'm mindful of the paper that we've just had a few moments ago, with the relevant confidentiality in place, to be able to begin to track how these interventions are helping us, what impact they're having, or do we simply have data that covers the kind of broad prescription cost? Are we able to start drilling down into what parts of the system are putting what pressures, and then correspondingly, if these changes start to bite, people start doing different things, people start buying their own, rather than getting prescriptions, people start, you mentioned the cohort of people that are using, their lifestyle choices. If we can start getting people to change lifestyle choices and therefore not require these, do we have sufficient data granularity to track that? Or do we still need to work on getting better data? And I know that might be compounded because we've got individual businesses and practices and what have you, but some context on that would be interesting, please.
Caroline.
Absolutely. We can get right down as far as you want to go. Within reason, obviously locum clinicians will have to borrow someone's prescribing name or number, but no, absolutely, you can get right down to the level that you're talking about, which is of course how they track these the changes that are in the paper. But there's nobody at the moment telling people to buy their omeprazole or buy their laxatives. Another great lifestyle example. Paracetamol, I think, does sometimes get some airtime, but possibly not as much as it could.
Okay, that's good to know, because at least then we can, when we start getting to those difficult conversations, and you mentioned higher level decision making, and I think that data then helps us to be able to justify some of that higher level decision making. We are suggesting that we do this because my second question is more of a blue sky one, but again, building on John's point around prescription costs necessarily could be decreasing costs further in the system. And I'm just wondering, when national bodies and regulators look into approving new drugs, are these factors taken into consideration? Because we often hear in the media, such and such a drug is not being approved because it's too expensive. And that's understandable. If you look at just the drug cost alone, that's completely understandable, especially for new drugs. But if there are new drugs that are now doing things that old drugs couldn't do, and potentially they might have a system cost that filters through, whether it's around hospitalization or on the prevention side of things, preventing ill health or delaying ill health until later on. Are these factors considered in those decision making, so that we know that the information that we get when we decide we will prescribe such and such a drug is based on that wider context? Does that make any sense?
Yeah, shall I come in on that one?
Yes, please.
Chair? Yeah. So yes, absolutely. So there's a formulary group. So before anything goes in the formulary, it goes through a process. And I remember, and I know this because I remember within the last few months contacting medicines management because we see the price of these drugs, by the way, when we prescribe them. It comes up saying, so if I see something that's very, very expensive with my medical lead hat on, I actually contacted medicines management saying, never heard of this drug before, is it okay? And the reply I got was, yes, this has been proven to reduce bed days or reduce admissions, so therefore this is absolutely on the formulary. So I know firsthand that these things are absolutely considered. Yes.
Thank you, that's good to hear. Thank you very much.
Thanks. Can I just ask one final question, which is, does the work on prescribing efficiencies, all of that analysis, is all of that fed into the budget working group, so that they have a good understanding of what are the potentials for savings through reforming activities, through trying to influence prescribing behaviour? Just is the work being translated into the language of savings, I suppose, for future action? Susie.
Yes, it is. I think the caveat which the group is aware of is the lack of control we have, and that the risks associated with that. So, there's a potential of savings with any of these, but again, it's a lot, as we've explained already, it's a lot around patient behaviour, there's a lot around clinical behaviour, a lot around need. So actually demand, we can't control the demand that comes in. So I think the issue is we've got a lot of activities, but in terms of our actual levers to pull against that, the influence, it's an influencing thing rather than a definite, and that's the thing that is really, really hard to judge, because you don't really know. So again, we are doing everything that we can and focusing all these different activities. But again, the outcome is actually, to be honest with you, is a guesstimate at best.
Yeah.
I think, Caroline, would you agree with that?
Caroline.
Yeah, no, that's what I was going to say, because we're down to patient behaviours of a different kind. So you can ask the GPs to make changes, but the patient has to accept them. And if the patient says, "But I don't want to change," we never force the patient to do something against their will. We're certainly not at that stage anyway. So yeah, that's a different kind of patient behaviour.
Yeah, well, I mean, it can be
unpredictable.
very challenging to introduce new approaches, and with family health services are evolving, greater pressures, getting the solutions is introducing solutions and improving outcomes can be difficult, can require a long-term conversation. But I think it is important that we keep on talking about prescribing and the prescriptions budget. So thank you very much, Susie and Caroline, for your contributions there. Can members agree the report, approve the recommendations? Yeah, that's great. Thank you very much, everyone. And on to our last item, which is the internal audit update report at 7.2. Jamie, sorry to keep you. Is Jamie there?
Yes, Chair, thank you.
Sorry to keep you, Jamie.
No apologies. I always attend committee. So yeah, this is just our standard report. We provide update on the status of the plan and the follow-up recommendations. No individual audit reports today, but I anticipate the Health and Social Care Staffing Scotland Act report will come to the February committee. And then the report concludes with a follow-up of one recommendation. Again, a really good position to be in, with only one being extended. So if I can take any questions, but thank you, Chair.
Thanks very much. So we've got their financial sustainability review scheduled for the IGB. That's very important strategic one. Any questions for Jamie? Can we, Richie?
Just a quick one to help Jamie, worthwhile Jamie hanging on for the end of the meeting. Just in terms of that financial sustainability review, is there anything really briefly you could share just now on how that might be done, and I guess the scope, and does that will be drawing on any other IGBs, which clearly it'll be a national thing as well as a local one. So is there any brief comment you can make at this point, Jamie, or is that better to wait for later on?
Thank you yourself, Chair. Thanks, Richie. So we'll scope that in the new year and look to come to committee probably around April, May time. Yes, certainly bringing in from the other two local IJBs, so Moray and also Aberdeenshire, but also tapping in essentially to my work through the Scottish Local Authorities Group. In terms of the actual scope, that's something I worked through with Fiona, NHS Grampian as well, so wouldn't have anything to commit to just now, but we do really want to kind of get some assurance around the financial sustainability and provide this to committee in the new year.
Yeah, grand. Okay, thanks for that. Can we agree the recommendations for that report? Okay, it's all agreed. Thank you very much, Jamie. That was our last item. The next meeting is the 24th of February 2026. I look forward to seeing everybody there. My time as chair of this committee has expired, so I will no longer be there as chair, but as a member. So I'd like to express thanks to everyone who supported me in my role as chair of the RAPC committee, particularly to Emma. It's a great team, and I'm really grateful for the help and support to help me in this role. So thank you very much. That's the end of the meeting. Hussein.
It was literally just to do the reverse of what you've just done, Chair, and to thank you for your leadership over your time as this committee, and we look forward to working with the next chair, and then to thank you for facilitating the discussions that we've had and the progress that we've made as a committee.
Thank you. It's a great professional, compassionate team. So thank you very much for those comments. And then Martin.
And similarly, on behalf of senior leadership team and in the absence of Fiona, just thanks very much for your chairing of the committee and your support to senior leadership team. We do appreciate it, and we look forward to working with you on this committee and the IGB. Thank you.
Thank you. Okay, but thank you, everyone. That's the end of the meeting. See you in February. Thanks.
Take care. Bye-bye.
Thanks. Bye.